There we go. So we want to make sure that we're able to help you in any way possible. This session for this webinar is called Taking the Mystery Out of Medical Billing for Dental Implants. Some of you might know me, some of you might not. I worked at a very large perio practice here in Seattle, Washington, in which found that medical billing was basically not only an option, but was very, very helpful for our practitioners as well as our patients. Our goal is to get our patients healthier faster, and in which it created a revenue stream of medical billing so that we were not even utilizing their dental benefits for their treatment at the periodontal office. Again, a lot of people have asked me what's the ratio as far as what I medical billed versus dental billed. And if I had to put a percentage on it, I would say between 60 and 70 would be a medical bill versus a 30% of what I bill to dental. So we found that it's very helpful, and we wanted to make sure other people would know how to do what we were doing. The whole Devdent team is wanting to be a resource for you. Everyone at our company wants the very best as far as helping your practices move forward. I do want to make sure you know there is a chat feature that you can ask questions, and please direct those to Q&A. That way we can make sure your questions get answered. If you have a complex question or specific coding question, if we ask that if you could please email those to support@devdent.com. Again, that's support@devdent.com. And that way we can make sure those questions are answered as detailed as they need to be. If time permits, we'll ask some questions on the forum, or at least go over some of the questions and answers that might have come up. We certainly hope this will be a help to you in moving your practice forward for medical billing and dentistry. Okay, let's get started. I'm sorry. We do need to make sure you know the presentation is for discussion and education purposes only. It is not intended to be used as legal advice, nor do we own the codes. They're owned by the ADA and the AMA. So please make sure you know that. Here's what we wanted you to look at: dental versus medical coding. When we talk about the implants that we're billing for right now, we're looking at 1 to 3 implants, or the 21248 medical procedure code. And that equivalates to our D6010 in dentistry. With that, there is another code for 4 or more implants. We utilize those for our all-on-4 cases and full mouth restoration. That's going to be another webinar. So I want to make sure you know that it is different. And also that we want to make sure you know that it will be addressed. It's just not going to be addressed in this webinar. So all-on-4 billing is completely its own separate type of billing. But within this, we have the root, or the surgical post that we place with the D6010 and the 21248 medical code. The abutment that goes inside of that as the D6056 and D6057, which is prefabricated or custom abutments. And that also is the same code, 21248, because the code 21248 consists of the cylinder that goes into the bone as well as the abutment that goes into the cylinder. We will talk at the end of the webinar so that we can show you how to utilize if you are only doing the restoration portion, and how you can be able to medical bill that portion. The crown itself, the D6058, is a 21089 in medical coding. You will need the qualifier. So the 21089 is a miscellaneous code, and the D6058 will describe what that miscellaneous code is so that you don't have to give them the description. So let's get started again. We're looking at the D6058 for your crown, and medical equivalent, the 21089, using the qualifier to be able to tell them what that miscellaneous code is. the abutment, which is the 21248, which also consists of your implant, the D6D10. So those three pieces are what we're going to be discussing today. Why is this important? And you can see I've put easy and hard. So doing one dental implant sometimes can be very hard, especially if your patient doesn't remember when that was taken out or the circumstances that surround that. If you have multiple implants with multiple conditions that are affecting your patient in the oral cavity, I say those would be the easy ones that you're going to be billing. So is it a complex of easy and hard? Yes. Some of your edentulous patients might not remember all the circumstances in which they needed to have those teeth taken out. And when we come to coding, our primary diagnosis code is telling them how they've lost these teeth. So we need to have that information. That's why medical billing for dentistry regarding implants can be easy and yet hard. So please know that we're here to help you the best way we can. Sometimes it takes more investigation. You'll feel like Sherlock Holmes in that you'll be looking for all the clues that are going to help you find the exact code that will help make your case to medical billing. In other words, what's the why? What's brought about this change in the oral cavity that's created the necessity for us to bill medical insurance? So yes, medical billing for dentistry can be hard, but it could also be easy. I tell people the more you do it, the better you get at it, the easier it comes to you. So when it comes to implants, yes, you're going to find some hard cases. You're going to find some hard cases that are so difficult that there's not much that you could do in order to facilitate reimbursement for that case. Again, you can only help those that you have the information in order to support your documentation. So please know, give yourself a little break on those hard cases and look for the ones that you might be able to bill easily. With that, let's talk about the principal diagnosis code for implants. The principal diagnosis code is the condition established after study, in this case surgery, to be chiefly responsible for care. This means for the implant, if you caused the loss of teeth by removing the tooth, what was the cause of loss? In other words, why did that tooth have to be taken out? So you'll see I also put on here, because we're talking about the mystery, I wanted to make sure that you knew that we're actually trying to solve these mysteries. So mystery number one solved. Your principal diagnosis code must reflect how the tooth was lost, either caries, perio, other, trauma, and what classification or class does the supporting structure have? I like to call the classification portion something that we do in dentistry, as in what is the long-term prognosis of your placement of this implant. So we do that with our classification, and we're going to go further into detail on that so that you have a little more foundation to support what you're going to be able to talk to your doctor about and what kind of coding you're going to need to do that. So again, the principal diagnosis code is the condition established after surgery to be chiefly responsible for the care that you're providing for this patient. So let's talk about what information this primary code is going to consist of. It's going to consist of what type of loss. Is this partial or is this complete? And again, I spoke a little bit about this in that the 21248 code is for 1 to 3 implants and the 21249 code is for 4 or more. So in that, the partial is going to be consistent of the 21248 code. So you'll need to know, are we completely restoring this arch or are we partially restoring this arch? 1 to 3 implants or 4 or more. You'll need to know what type of loss. Is it partial or complete? What has made the teeth hopeless? Periodontal disease, caries lesions, other oral systemic cause, or trauma? Those are things you have to know. You can't I tell people I can't make it up. I have nothing to support that. By saying that this patient has periodontal disease, that doesn't give me anything. Number one, I am not clinically able to say that, and so I can't make up something that's not there, and neither can you. So being clear and concise and going by what the doctor states in the diagnosis is going to be very prevalent in your medical billing. And then we're going to look at the last one, which is what classification of bone. And I say here, class 4 means serious surgery. So serious surgery must be completed because the bone is not good or the support structure. And we're going to define that a little more. I would very much hesitate to ever tell you to use class 4 in your classification series. It basically says it does not matter. We feel that the bone structure is probably not going to support the restoration. So please be wary of class 4 implants. Making sure that you're looking at the scenario. This patient is a type 2 diabetic that has periodontal disease. They have a partial loss of teeth due to this perio disease, and the primary diagnosis code to describe why the extraction and implant must be completed. So in other words, they have a partial loss of teeth due to perio is going to be my primary diagnosis code. From there, I need to find out from the doctor, how does he define the bone health by putting a classification or a class type on there? It will give me a very specific code. That would be how to tell him how my patient ended up in the chair, taking out the tooth, and now what do we have? What is the highest level of care that this patient needs to do a restoration? So I wanted to show you that our team has been great. They put together this classification guide. It is going to be a free gift to you for attending this webinar, and it will be emailed to you about an hour following the conclusion of the webinar. But this is very in-depth, and so that you have an idea of what the doctor has to go by for determination of the classifications. If you'll see at the bottom, the diagnostics criteria key tells you the different areas the doctor has to examine in order to come up with that class 1, class 2, class 3, and class 4. Again, I steer you away from class 4. Please, please, please. Be very wary of telling them your patient is a class 4. If that is the truth, then by all means, please use that classification. But let's review what class 1 entails. We're looking at number 1 for A, the location and the extent. Is it ideal or minimally compromised? Confined to a single arch? Does it not compromise the support of the abutment? So when you place the implant, is it going to not compromise the support of that abutment? It'll include any anterior maxillary span that does not exceed 2 incisors, any anterior mandibular span that does not exceed 4 missing incisors, and posterior span that does not exceed 2 premolars or 1 premolar and a molar. So that's the first set of criteria regarding location and extent. The second portion is going to be the condition of the abutment teeth. Abutment teeth condition for class 1 is ideal or minimally compromised. No need for pre-prosthetic therapy. So thinking of your class 1, it might be your 1 or 2 implant cases that possibly were a trauma case and they were knocked out and now you have to replace those with an implant. Thinking things like that, but I want you to get the idea of what the doctor's looking at when he's giving you what classification this patient's oral cavity is in after that extraction. So look to see the occlusal scheme. What that is looking for is that it is ideal or minimally compromised. There's no need for pre-prosthetic therapy, and the maxomandibular relationship, the class 1 molar and jaw relationships is in good condition. So basically, you're looking at very good structure. not much necessary to get these implants placed, and or maybe not minimal bone grafting that needs to be completed. But look also for the residual ridge. The residual ridge morphology for class 1 is complete edentulosum description. In other words, once we place this implant, this patient will be complete. Their arches will be complete. Every aspect of the ridges will be met. You're putting them back to complete restoration with this lower class of oral bone. So this is really your bone health and the ridge, how the ridge will support the restoration. Class 2, we're looking at a little bit more. Again, looking for location and extent. We're looking for the moderately compromised that's confined to a single arch still. It does not compromise the physiological support of the abutment teeth. And then, so remember, it does have all of the locations. So remember, I say this because being a doctor is hard. I mean, they have so much knowledge, and we have to make sure that we understand we cannot make this determination. It is the doctor's determination, but we should understand exactly what they're looking for. When it comes to class 2, condition of the abutment teeth, we are looking for moderate compromise, moderately compromised areas, as well as 1 or 2 sextants that have insufficient tooth structure. In other words, possibly you're placing 1 or 2 implants in the lower right, but the upper left will also need an implant. So it's a little more compromised because the area that you're working on isn't the only area that needs work. So making sure that we understand kind of the areas that the doctor's looking at. So when we get over to the occlusal scheme for class 2, we're looking at more localized adjunctive therapy. For instance, you do place 2 implants on the lower right, but the upper right also needs to have scaling and root planing. So you have a little more criteria that of work that needs to be done. And then also when you go to the residual ridge, you're looking at, once you get them back to the same morphology of the class 1, they're going to end up with complete edentulosum as far as the restoration of the arch. Now we're going to get to class 3. And I promise that this one's hard. Most of my all-on-4s ended up as a class 2 or 3. I never had a class 4 in an all-on-4. But I want to make sure you realize we're still talking, again, 1 to 3 implants. I don't think you're going to have very many patients that are going to end up in a class 3, even placing 3 implants. But that really needs to be your doctor's discretion, but you need to know what he needs to look for. Class 3 means that location and extent is substantially compromised, that the edentulous areas may be in 1 or both arches. So making sure what it kind of fits together, but it also does compromise the physiological support of the abutment teeth. So are those abutment teeth compromised in any way? So when you place the implant in and you put the abutment on, are they going to be compromised in any way? Is there a good success rate, or do you have a good prognosis of success for this patient? I honestly believe our practitioners would not place the implants unless they believed there was going to be good success. Again, if you move down on the criteria for the condition of the abutment teeth to the bottom of that criteria, it says abutments have fair prognosis. So when we would do restorations and ask them they would always ask us, what is the prognosis? Give us a 5-year prognosis. And we're always saying they have an excellent 5-year prognosis. They have a good prognosis. They have a fair prognosis. And then they have a poor prognosis, being your class 4. So again, think of it this way. We really say the same thing in dentistry that medical's looking for. But when we get this classification, it gives us a specific code to tell them what we're doing without writing any kind of narrative. So let's move forward. So we've got class 1, class 2, and class 3. Those are the ones I'd like you to deal with. I'd really like you to stick to class 1 and 2. and leave 3 for your more compromised patients. Now, you might use class 3. It definitely has to be something the doctor deems necessary as far as telling the truth. And that's something we definitely want to do. Let's take a look at the diagnosis codes that we're using or looking at for our primary for implants. So if you look to the left, you'll see the loss due to trauma. Again, the 21248 for 1 to 3 teeth. You'll see there KO8411 is class 1, and it increases by 1 number to 412 for class 2 to 413 for class 3. Going down, you'll see loss due to perio. Again, the 21248, it's K08421, class 1. Going up a number to 422 for class 2 and 423 to class 3. Moving over to the next column, you'll see the loss due to caries. So making sure that we know there's a loss due to caries. There's a reason of why these teeth were lost. We're looking at K08431, again going up a number, class 2 being 432 and class 3 being 433. Moving down one, we're looking at a loss due to other. Now the other is mainly going to be your congenital and or the things that are not classified for caries or perio. Looking at the K08491 for class 1, the 492 for class 2, and the 493 for class 3. So those are our primary codes that we can use. Believe it or not, those are all you can use for implants. So you cannot branch out anywhere from this when you place 1 to 3 implants. This is your diagnosis code, whether it fall under the trauma, the perio, the caries, or other. Okay, now your secondary diagnosis code. So believe it or not, your sequence matters. I want to emphasize that the sequence of codes tells the story. The secondary diagnosis code is the condition that coexists at the time of the exam, that develops subsequently, or that affects the treatment received and or length of necessary treatment. So think of it this way. Your secondary diagnosis code is what caused the caries, what caused the perio, what caused the other. So what is the cause of those things? So here's your mystery number 2 solved. Your secondary diagnosis code must not relate to an earlier episode, which has no bearing on the current treatment. Here's your scenario. You have a patient that did a root canal therapy, and this patient might be xerostomach as well as have, let's say they have asthma and they have an albuterol inhaler. So now you have a patient who uses an albuterol inhaler, has xerostomia and caries. And now that root canal tooth that you did prior, all of a sudden now has such caries that it needs to come out. You're going to have a partial loss of teeth due to caries, not prior root canal therapy. The root canal therapy that you did before has no bearing on the current treatment that you're doing for this patient. So I hope that does make sense for you. A lot of people will ask me, well, this is a prior root canal tooth. That prior root canal tooth has nothing to do with the treatment that you're doing for this patient now. So what it means is the condition that coexists at the time of the exam. In other words, what has brought along the cause of that. There could be some things that develop subsequently to your exam that still could affect the treatment and the effect of what you're doing. How does this look? Let's take a look at some of the secondary possibilities for implants. And of course, please note, this is a partial list. I wanted to give you an idea of things to look for under the categories that we bill for our primary that could make sense in telling your story. For perio, how about looking at hormonal changes? This goes from pregnancy to menopause to low testosterone. any kind of hormonal changes can bring about some kind of perio, whether it be chronic or whether it be aggressive. It really depends on some of the things that your patient might be going through. Cancer really can affect your perio, sometimes more than others. So if you think about an oral cancer, you know that that's going to highly affect the perio within the oral cavity, and some others depending upon location. HIV, medications, smoking, poor oral hygiene. Believe it or not, there is a code for lack of oral hygiene, or I'm sorry, lack of personal hygiene. So if that's the case, you use the codes that are applicable to the patient. So how about going to caries? Caries, we're looking at GERD. GERD is something that is diagnosed that our dental providers cannot diagnose. We have to confirm its existence. So there are things that we can diagnose, which are of the head and neck. There are things that we cannot diagnose. That's anything outside the head and neck. So when you're talking about cancer, HIV, any of those things, they must be confirmed by their medical doctor. So we're looking at xerostomia. Xerostomia is something our doctors can diagnose, as well as dry mouth, but it could also be related to you as a symptom. In other words, a doctor might say, I don't see the signs of xerostomia, but the patient relates that they experience a dry oral cavity. So that is related as a symptom. You have acid reflux and heartburn. And while we know that GERD and acid reflux and heartburn manifest in the oral cavity, they are stomach-related diseases. So we need to make sure we get confirmation from their medical doctor as to exactly what is going on, and what diagnosis codes they are using to treat those specific things, as well as eating disorders. And I do want to warn you to please be careful with the people who have eating disorders. They are not likely to want you to utilize that unless they're in recovery. So please make sure you review with your patient. You know, if I bill this, it will reflect that you have this eating disorder. We want to make sure that we're being fair to our patients. We have to tell the truth, but they might tell you, I don't want to bill dental, or I don't want to bill medical insurance if that's what we have to go with. And medications is another thing that can bring on the xerostomia, which also brings on a lot of caries. So if you think of this, caries lesions are infection that do not get better by themselves. They need to be removed, and or they cause such decay on a rapid scale that there's no other way for us to treat that tooth but to remove it and place an implant. The other falls under, again, anything that is not under perio and caries. So we're looking for things like amelogenesis imperfecta, osteogenesis, endodontia, aplastic anemia, ectodermal dysplasia, cancer and radiation. Those things are high on the list under the other. Again, what they state in the code is anything that you cannot classify as perio or caries, they ask you to state it in the other category. I do want to talk a little bit about trauma. So your secondary trauma codes must be based on what the trauma was, or what caused it. What's caused this loss of tooth? So say, for instance, you have a fracture of the tooth. So you're doing an implant due to trauma, partial loss of teeth due to trauma. And that trauma was they were struck in the mouth accidentally while playing basketball. Your second code would be struck accidentally. Your third code would be playing basketball, as long as we're telling the story. I like to tell in our courses, the way we code for medical is somewhat backwards from what you're thinking. I want you to think about when your patient walks in the door and they've told your staff, well, they're coming in because they're in pain. Well, pain is a relatable code. It's whether it's jaw pain or whether it's just regular pain. We make sure that's part of our code sequence. But that pain was caused from what? Was it infection? Was it being struck? Was it that he was playing basketball? So say, for instance, this patient was coming in pain. They were playing basketball. They tell the doctor they were struck with an arm as they were trying to reach for the ball, and that knocked their tooth out. So as I tell you that story, I'm telling it to you medical coding backwards. We would really start our first code with a partial loss of teeth due to trauma, our second code being struck accidentally, the third code being basketball, and the fourth code being pain. So again, making sure we're telling the story for the patient. There's an etiology of the loss, whether it be perio, caries, other, or trauma. The first thing to think about is the science and study of the causes of disease and their mode of operation. In other words, knowing that periodontal disease can be really influenced by diabetes, it will help you know the etiology of what type of loss that patient would have. And again, our doctors are the ones that give us the diagnosis. Sometimes it's written in the inside of our chart notes, and sometimes we have to dig for it. Sometimes you are Sherlock Holmes and you're looking for the clues of what could be going on with your patient. The second thing is the science of causes, or the causality. In common usage, what is the cause itself? What created those caries lesions? What created or what started the perio? Now, sometimes it's hard to define. A lot of times a good health history will help direct, and having the doctor look at what we have going on, and they could say, hey, I saw this patient 6 months ago and we didn't have six areas of caries, and two of those now have to be pulled because of the severity of the caries. So looking at the bottom, we have a partial loss of teeth due to caries caused by xerostomia brought on by Sjogren syndrome. So that would make sense in our story for having to remove those teeth. So the teeth were lost because of caries caused by the xerostomia. Now we're looking at the second scenario. We have a partial loss of teeth due to periodontal disease, which has been caused by type 2 diabetes with perio. Now, to be honest, I only have two codes there, but I really have three definitions. I have periodontal disease as why the tooth has been lost. But because diabetes is so prevalent in medical, it is only one code: type 2 diabetes with perio, type 1 diabetes with perio. The only other option would be type 2 diabetes with oral complications or type 1 diabetes with oral complications. But they're so intertwined that we really have one code where two could have been. So you're really using two codes to make your claim or your statement and tell the insurance company the story. Signs and symptoms could be possibilities for our third and fourth type coding. So we talk about the dysphasia or the swallowing issues. If you can't chew your food effectively, you will have a sort of dysphasia. We are speaking specifically about the oral phase, because dysphagia can go all the way down the trachea and into all the way down. So we are speaking specifically about the oral phase or the mouth. So utilizing this code, your patient says, I have a hard time chewing and swallowing. Well, that is the dysphagia in the oral phase. Again, we talked earlier about pain. If the patient doesn't say jaw pain, which you can see is 2 down, that's specific. But if they say they're in pain, my mouth hurts, that is pain. If your patient states dry mouth, again, that's what they're stating as a symptom. That's one of the reasons they might have come in to see you to begin with. Again, looking at your perio, there's two types. Either it's aggressive or chronic. There's 3 questions that need to be answered regarding perio. So you have aggressive and chronic. You have localized and generalized. Then you have slight, moderate, or severe. So making sure clarification is on what type of periodontal disease our patients have will also help us get more specific in our codes. You see anxiety on there. Now, anxiety doesn't have anything to do with the loss of teeth, but anxiety comes into play if you're doing IV sedation. You're not doing IV sedation because you're placing an implant. You're doing IV sedation because your patient is anxious. So utilizing the code where it's best effective is making sure you know that the code could apply. Cellulitis or abscess of the mouth, what is your infection? Does the patient have an infection that's causing part of the reason of loss? Or are they on long-term use of insulin or inhaled steroids? You have systemic steroids, somebody who might be taking a lot of prednisone, or you have your aromatase inhibitors, or your antithrombotics or antiplatelets. They really do have an effect on the oral cavity, as well as your NSAIDs and your aspirin use. Now, again, medical providers are not trying to say that they're going to hurt people and they're going to hurt people's oral cavity by prescribing them this medication. What they're saying is the side effect does not outweigh the benefit that this medication is going to do. So please don't think that a medical doctor is trying to cause problems in the oral cavity. They're trying to see that the likelihood that the medication will benefit them versus cause a side effect. So we can use these codes if we know that these are valid codes that our doctors have prescribed, the medical doctors have prescribed, and that is what's causing the difficulty in the oral cavity. So let's talk about the sequence, because I mentioned that earlier. Your diagnosis code sequence is very important to make sure that the medical insurance has all factors involved with why this treatment is medically necessary. So remember, we have medical problems with dental solutions. So here's your mystery number 3, your solved mystery number 3. You can tell your patient's story in 4 diagnosis codes or less. You can. It's making sure you use relevant codes. Your patient might have a lot of difficulties. Your patient might have a lot of medications. But what medications directly affect the oral cavity? And according to what your doctor said, if they have a loss due to caries, a loss due to perio, a loss due to other, how is that affecting those? So we have a little test here. We're going to talk about this, and then we're going to see if you can get the right answers. Will you have a Sojourn's patient with severe xerostomia causing severe caries of 3 teeth in the maxillary arch and difficulty swallowing? Surgical extractions, this is your treatment plan. Surgical extractions, 3 in total. Bone graft, membrane, implants, abutments, and denture, which should be crowns, are required. It could be an implant-supported denture that spans those three teeth. Let's look at what our possibilities are for our primary diagnosis code for our extractions, abutments, and our implants. Is it K08.422, partial loss due to perio class 2? Or is it K08.432, partial loss due to caries class 2? So get your answer. We're going to go over the answers in a minute. How about your primary diagnosis code possibilities for your bone grafting and your membrane? Is it K08.24, minimal atrophy maxilla? Or is it K08.21, minimal atrophy mandible? Now remember, that's for your bone grafting and membrane. The extractions, abutments, and implants will have its own primary diagnosis code. The primary diagnosis code is for the service you're performing. Now, how about the secondary diagnosis code possibilities for all? That encompasses all of the treatment, the extractions, abutments, implants, bone, and membrane. Could it be a disturbance in salivary being xerostomia, the K11.7? Or could it be R69.2, dry mouth? So think about that. Get your answer. Now let's look at the 3rd and 4th code possibilities. Does the patient have J37.0 chronic laryngitis? Or B, M35.0, Sicca syndrome or Sojourns? Or does the patient have M35.9, Sicca syndrome with organ involvement? And that's not organ like you're playing the organ, it's organ as your internals. And is it D, R1311, dysphasia oral phase? So I hope you have your answers. We're going to go forward. Here's your answers. Hopefully everybody got them, because in your scenario, the patient has caries. So it would be a partial loss due to caries class 2. And then for our bone grafting and membrane, it says specifically it is in the maxillary arch. So we're going to use the code for the maxillary arch, K08.24. The secondary diagnosis code possibilities for all of those would be K11.7, disturbance in salivary or the xerostomia. And for the third and fourth, we know that the patient had Sojourner's disease and dysphagia in the oral phase, difficulty swallowing. So our third and fourth code would be the Sicca syndrome and dysphagia. How you would code your partial loss of teeth due to caries would be K08.432, K11.7, M35.0, and R13.11. My patient came in because they were having difficulty swallowing. They have Sojourner's disease, which has caused xerostomia, and now we have a partial loss of teeth due to caries. So I hope that makes sense for you. If not, please let me know and I'd be glad to clarify that. Let's talk about a second scenario. We have a surgical extraction bone graft membrane and implant due to the following medical conditions: severe perio, type 2 diabetes with perio, moderate atrophy of the mandible, and jaw pain. Now we're going to put these in order, and I'll give you a hint. Your implant placement and your surgical extraction sequence, ABCD or DCBA, however you put it, are going to be the same. Your bone graft and your membrane are going to be the same themselves. So I'm going to give you just a second. Okay, your second's up. Here's how we're going to look. Our patient number 1 has the implant. The primary diagnosis code is B, partial loss of teeth due to perio, C, because of type 2 diabetes with perio, and D, jaw pain, because that's what the patient stated. Our bone graft line, A, moderate atrophy mandible, C, type 2 diabetes with perio, D, jaw pain. And notice our membrane and our surgical extraction, the extraction following the implant placement and the membrane following the bone graft. If you'll notice, I put highest fee first. Want to make sure you know, if you're doing this on your own, your highest fee needs to be your top line. They will pay you the most on your top line and reduce services the more lines that you have. Your modifiers. There's only 3 modifiers that come into play with implant billing for dentistry. Bilateral, so say for instance you place an implant on 6 and 10, you can use the bilateral modifier so they know you went over the midline to place the other implant. Multiple procedures. If you're placing an implant in the upper right and the lower left, you're doing 2 1 2 4 8s, and it's multiple procedures because you're in different arches. 52 for reduced services, when you don't complete everything the code entails. This modifier is used when you're restoring with the abutment piece only, and if you're using granulated bone graft material, because the code for bone graft does say it includes the obtaining of bone. When you use that modifier, it reduces that service. So I want to show you Imagine Billing and how we can take a claim full circle, going from the verification of benefits all the way through to a paid claim. So if you look, we're going to pull up Jane Addams, and we're going to make sure we have all of her information, including her insurance and her card on file. You must upload your card so that we can be able to fight this claim for you. Clicking on verification of benefits, the verification of benefits is saying the procedure you want to do is considered, and this is the percentage rate that it could be paid at. You can go CDT or CPT, it's up to you. But if you know your dental codes, you can type your D6010. It'll say endosteal implant and give you, is it 1 to 3 or 4 or more? We're going to click the 1 to 3. And now we're going to also do an additional procedure, a D6190, which is a radiographic implant index by report. And we're also going to look for a cone beam, 70486. Once you put your D code in, it will give you the common procedures. If you don't see what you're looking for, you can actually go in the search CPT, type in something or scroll all the way down so that you can see something that you need. Now we're going to go to next. We're going to upload their insurance card, and now we're going to submit this over. Say confirm, and now that has gone over. We do have a 24-hour turnaround for verification of benefits. The cost is $35. Once you pull it up, if you decide that you want to do it yourself, you have all of the information that you could do it yourself, making sure you ask for in-network and out-of-network deductibles and coinsurance. And if you look here, it brings over all those procedure codes that you're looking for. So once we send it over to Imagine, we're going to pull it back up. You'll see it in your cases that it is pending. And then within that 24 hours, it'll start to come through as completed. So from there, you'll also get an email as well as the little bell up on the right-hand side will show you that that verification of benefits has now been completed, and you can look at it. So you can see that once we refreshed our screen, it brought that verification of benefits through and shows you right there that that verification has been completed. We click on that, we can see exactly who our billers have talked to. They verified their eligibility as well as when they renew. They have their in and out of network benefits and deductibles. They show you what percentages per procedure code, but also that they are requiring a pre-authorization. It'll also give you additional details in the notes if we find anything else out that needs to happen. So say, for instance, that gap exception has to be requested by the patient or something like that. So once we get back to Jane, we're going to look now, since we have our verification, we want to do a pre-authorization. We want to make sure that our why is approved. So the verification of benefits says that our what procedures we want to do is approved, and our pre-authorization says why we want to do that is approved. So it'll bring over all those 3 codes that we had used. If we say, hey, the doctor has added another one, we can click that blue plus sign, and it will give us the opportunity to add an additional code, or 2 or 3, just depending upon what you might find that your doctor needs to have done. So if you look to the left, all the clicked items are the things that are being sent over for the pre-authorization. And we're going to put our teeth numbers in, how much our fee is per unit, how many units we're doing. So the fee multiplied by the number of units will give us exactly how much we're going to be billing for this service. So again, looking at the guide for the the surgical index and radiographic index, I didn't say that correctly, as well as our CBCT. And then if you look to the right, that green little wand has the smart code. It tells you what are the common diagnosis codes used for this specific procedure. And we're going to find the exact code that we're looking for, and which is partial loss due to other. We're going to save that. And if you wanted to, at the bottom, you can add diagnosis codes here by category. You can select the diagnosis code feature. So if you clicked on loss of teeth partial, you could find that same code that we just found in the smart code with the little green wand. And that way you'll be able to have some help on what you could pick for that specific code. So now we're looking for GERD. So we typed in GERD. We had to click it back to all, and now it pulls up with the GERD diagnosis code. We're also going to pick a couple of others. So we have erosion on those teeth. We're going to pull up erosion of teeth. And we also have a little bit of personal history of thyroid. So we're going to pull up that this patient has personal history of a malignant neoplasm. So now we have 4 diagnosis codes. Here we can put them in order. So what's the order that best describes the story of this patient? This patient who had a neoplasm in the thyroid now has erosion of teeth due to GERD, and now we have a loss of these teeth. So telling the story. To the right, you'll see the red X. You can take out what you have that you don't need if you're not going to send that over. Now you can click next. It'll take you to where you upload the clinical notes. These are the exam notes that we need. The exam notes so that now we can put this pre-authorization in for you. So moving forward, we're going to click on the documents, upload those, and they'll be there for the billers to fight for you. Submit that over to Imagine, and now that's going to be submitted on your behalf. So from there, you're actually going to get to click over and submit your claim once we have all the information. It'll say in that pre-authorization approved, it'll say, yes, you might have partial pre-authorization. So a lot of times my extractions are not part of my implant pre-approval. They don't cover the extractions the way they do the bone graft and the membrane and the other. So once we have that in there, now we can actually go in to submit a claim for this patient. I'm sorry, she's going to show you that it is submitted. So let's go back to Jane. And this just shows you the detail, and any updates, it will show up there. Anytime you're doing your medical billing, whether it be through Imagine Billing or on your own, you need to age your claims so that you know which ones need to be followed up on immediately. To be able to submit this now to medical, all we have to do is create a new case and a claim. And from there, it's going to be sent over. We pull up all this. We need to find out, do you want to accept assignment? So you'll click down, and this is whether you're billing it on your own or through a software. You will have to tell them whether or not you want to accept the assignment or you want the check to go to the patient. You'll say next. Now this is going to bring up all those 3 codes and the diagnosis codes. You'll check which ones you want to submit and give the date of service that the services were completed. When you do a billing for, say for instance, a night guard or palatal expansion or something, you do have to make sure that it's on seat date. The modifiers, it'll tell you the modifiers that are commonly used also with this code, whether it be multiple procedures or waiving Medicare so that they know you're not filing to Medicare. Moving down, if you bill dental before medical, you'll be able to put the amount that was paid. So was there an amount paid to you by the dental insurance? You'll be able to put that in there so that we can have full disclosure, making sure that we abide by law. So once we do that, it's gonna move us forward. We're gonna take that claim and we're gonna submit it over to Imagine. We can also change the diagnosis sequence if we know that possibly the malignancy didn't have anything to do with the reason that we took those teeth out. Adding the document for the surgery itself so that in case they want proof that we actually provided the service, we'll have it. And that goes again for doing it on your own or through a third-party biller. I don't know if you saw that the ADA put out the top 10 reasons that you should use a third-party biller, but it's a pretty good article. And it's, you know, if we were around when I was doing medical billing in my practice, I'd have jumped at it, because the hardest part in the facility while you're working is to follow up and stay on hold for claims. So please, consider it as an option. And then of course, going back to it'll tell you when it's submitted and when it's actually been processed. A lot of times our billers will find out you're getting paid before you do. So again, here is the actual final version of this claim and how it was paid out. I don't know if you noticed that when we looked at the verification of benefits, they said it would pay out at 40%, and it really did pay out at 40%. So all the codes that we used are there. Of the $3,700 that was billed, $50 was the member's copay, and they paid a total of $1,870.53 towards the treatment. So looking at your abutment and restoration, and I'm about done. Looking at the abutment, I want to make sure you know that the abutment, you have to use the modifier 52 because the implant was already placed, healed, and integrated when you're actually putting the restoration on. The implant crown being the 21089, utilizing the qualifier to make sure that you can tell them what the equivalent code is in dentistry. The diagnosis code sequence will follow what you already used or what was used for the implant placement. So if you are working in a prosto office, the implant portion that you're doing the restoration on, hopefully the doctor filed the claim, and so that you can follow the same diagnosis code sequence. I want to encourage you to visit our website to sign up and look at the course schedule that's there. There's a demo of the software that probably does a better job than I did at explaining it. But again, a lot of this is going to be for some of you easy. For some of you, you're just starting and it's hard. And I want to make sure you understand we're there for you. We have our Facebook group that's a closed Facebook group for medical billing for dental practices, Imagine Billing. So we want to be there for you in the things that you need questions answered for. So I wanted to take a second. I have about 3-4 minutes. I wanted to see if we can look at some of the questions that we have going on here. I'm just going to scroll through. So we have some of this somebody asked about pre-authorization. Yes, I highly recommend pre-authorizing your implants. Again, it's going by your notes. Please, please, please work on chart notes with your team. It has to be a full team effort. It is not a one-man show when it comes to medical billing. The only way I was successful was the fact that my team was great at chart notes and wanted to put in the chart notes everything that I needed. So the exam notes are what you need for pre-authorization. If your pre-authorization, if you say that there was erosion because the doctor told you and the chart note says nothing about erosion, I can pretty much guarantee your claim's not going to go anywhere. You need to make sure that your pre-authorization talks about what your why is and that your why is a covered service with that insurance company. One thing you're going to find funny is that medical insurances don't want your dollar amount. They only want your procedure code and your diagnosis code. So tell them the story and why it needs to be done. And make sure that your SOAP notes match what you're coding it as and what the doctor tells you. So make sure you're looking at the implant and the abutment. So the implant and abutment are one code, but can be billed out separately. We talked to Michelle is asking, do you need to get a medical diagnosis from your doctor? And you do, if it's something that you cannot diagnose, like diabetes and GERD, things like that, you have to get their confirmation. I call the nurse and I ask the nurse, I'm calling about John Smith, and wanted to see what diagnosis code you use for his GERD treatment at your office. And then I'll make a chart note and I'll say confirmed with Nurse Susie at Dr. So-and-so's office that the diagnosis code used for the GERD is such and such. And that's how I am able to bill those codes because it has been confirmed. So again, Dominic is asking about the criteria, the residual ridge. That's the supporting structure. What is the classification of the supporting structure or the morphology? What's it going to turn into at a later time? So making sure that we know that only our doctors can get this. We can only support what the doctors say. They're the ones who determine the classification. So making sure, again, it is going a little fast, Michelle, and I would love to do it in person. I would love for you to come to one of my courses because we really do get in depth with this and all on fours as well. So again, please also remember that within what you're doing for implants, the implant removal, so say for instance, somebody has severe peri-implantitis, and that implant has to be removed. Medical usually always covers that because of the infection. So I want to please make sure that you understand that is a separate portion. Also, the lack of personal hygiene, Polly, I can get that to you. So if you are out of network, there is no write-off. So I know that takes us up to our 5 o'clock hour. I would be certainly glad to discuss any of this with you, as well as any of our team at support@devdent.com. We're all there to help you and get you started on a path that I know personally has been successful, as well as I do still bill for 4 offices myself, just because I don't want to teach you something I'm not willing to do. So please understand that we want to be there for you. So if you have any other questions, please email them to support@devdent.com. We can get you detailed answers. The webinar will be up again. You will get this classification, the partial loss of teeth classification system, so that you can review that with your doctor, so that he'll be able to know and put loss of teeth class 2. So that way it can help with your coding, because it is a very specific code from there. I hope everybody has a great night. I thank you so much for coming. I count it an honor to speak with you. And I sure hope that if there's anything I can do, that you'd reach out to one of us at Devdent. Thanks so much. Have a great evening.